Hi, everybody. My name is Naomi, and welcome to the 7th webinar in our series on workforce priorities, how to attract, hire, retain the right people for today's behavioral health world. Sorry about that. And today we're going to talk that we have a very lengthy title here, when values aligned human resource tools to help your organization hire and support mission aligned staff. The simple version of that is we're releasing a toolkit that provides some resources for you to try to accomplish that mission of having your staff align with your values. So my name is Naomi, and I work for ICL, Institute for Community Living, as Vice President of Innovations, and I'm joined today by Amy Mendenhall. Amy, you want to introduce yourself?
Yes, good morning. My name is Amy Mendenhall, and I'm a faculty member at the University of Kansas School of Social Welfare. Great.
So today, as we've been doing in all of our previous 6 webinars, we start out with, what's the key question we're addressing today? So we're talking about using human resources tools to achieve our goals. So the question being, does the organization have a culture that ensures the right people with the right skills and the right attitudes are doing the right things, the right work, to get the right results? So that's kind of our guidepost. So I want you to just take a step back and just imagine yourself, other people you know, et cetera. So kind of once upon a time, we had a program called Pave the Way. And Pave the Way was a community reintegration program for formerly incarcerated people who have co-occurring mental illness and substance use disorders. And we have a program director, Angela, who's new to the position. She's new to the role of program director. And she's got an open position for a case manager. She's not living in a very urban area, but she's had 15 applicants who have applied, and she's going to bring some of them in to interview them. And like every program director who's faced with this, there's some decisions that have to be made about who to bring in and what questions to ask. So Angela, being the thoughtful person that she is, turns to Google, right? Gets her whole list of questions together, tries to figure out who to bring in. So she's going to ask some questions like, what's your plan for the next 5 years? And why do you want to work here? And what do you like about working with this population? And tell me a little bit about your experience and what got you here. Those kinds of things. But the reality is, in the world of behavioral health, we've got a lot of challenges in hiring that some places like Google, for example, don't have, right? There's the urgency of hiring, and sometimes we have new programs, so we have to hire lots of people all at the same time. We've got caseload limits that we have to adhere to for regulations, right? In terms of being competitive with salary and benefits, we may not have all the advantages of a managed care organization or a hospital or a for-profit organization. We are often advertising undesirable shifts, Saturday shifts, Sunday shifts, midnight to 8 a.m. shifts, right? Not everyone wants that. People have to pass background checks, right? The Justice Center has done a ton to protect the clients that we're working with, but it puts some stop points at the hiring process. We've got a broad range of work experience coming in. So if you take your typical clinic, you're looking for a therapist, you're going to have some people who are very new to providing therapeutic services in that kind of one-on-one setting, and other people who have been around doing it for a really long time. In rural areas, you may have fewer candidates with the required skill set. You may have people who have more customer service experience than one-on-one person-centered direct care experience. And of course, hiring is often not very scientific. But we also have this really high turnover. And so the goal is to try to reduce the turnover so we don't have to do as much hiring, and we reduce turnover by having better hires in the first place. So we developed a toolkit to respond to this. And the goal is to support the hiring, developing, and retaining of staff who match the values of our organizations. So this toolkit includes what we call here attitude surveys, but let's think about it as pre-employment attitude surveys, recommended interview questions that follow up from the pre-employment attitude surveys, and then once people are hired, performance measure tools to see how they're doing. So the quality, we're calling this kind of a quality care model, and this is modeled on ICL's TRIP approach. And TRIP is an approach, is an acronym that ICL developed, but it's not, all that novel in terms of what it's attending to. It's the same priorities that state behavioral health agencies are asking us to do, which is be trauma-informed, recovery-oriented, focus on integrated health or whole health, and be person-centered. So we call that TRIP, but for the purposes of this toolkit, we're calling it quality care. So, Amy, you want to talk and explain kind of how we developed this?
Yeah. So we started out thinking about how do we screen for these beliefs and qualities, and so we started by developing an attitude survey that could be given to folks who are applying for positions. And so we developed we started first by developing an attitude survey for program staff that tapped into those 4 areas. And then we also extended that out and did one for administrative staff too. That wasn't as detailed or as long, but still was tapping into some of those core qualities and core beliefs, but for administrative staff rather than program staff. Then after thinking about, okay, once you do an attitude survey, the next step is now you have this information, right? You have this information about the attitudes of the candidates who have applied for the job, and now you take that to think about, well, that then leads to interview questions, right? What do you need to know more about? Tapping into those 4 areas, if you have, and we'll have an example in a few minutes, but if you find out information about what someone's beliefs and attitudes are, you may need to dig in more, right? If there are really high scores in certain areas or really low scores in certain areas. And so the next step was the development of those interview questions where you could ask more about those specific attitudes and then the behaviors associated with them. After the interview questions, the next piece was, okay, now you end up making a decision to hire someone, but you still want to continue to track that even after a person is hired to see then how that translates into the performance once the person is on the job. And so with the performance measures, we also developed 2 different versions, one for frontline staff and then one for directors and supervisors. And this whole process was really an iterative process where we would work on one piece and then realize that we needed to go back and change something from a previous step. And so there was lots and lots of versions of all 3 of these to get where we are today, because we found that work on one step would lead us to, and piloting of one step would lead us to going back to need to change a previous step. And so it's really been kind of this ongoing cyclical process of editing, getting feedback, getting data, and then changing again.
So I want to talk, so what we're going to do is we're going to talk first about the pre-employment attitude survey, then we'll talk a little bit quickly about the interview questions, and then we'll go to the performance measures. And then as Amy just explained, the reality is that this did not develop in a nice, neat, we're going to do this, this, and this, and then we thoughtfully put all the pieces together. It was back and forth and forwards and backwards. And so it's been a developmental experience. So the attitude survey is a collaboration between ICL and the University of Kansas. We decided to focus on the quality care themes. We originally started out when Amy and I first started talking, it was really about making sure that people were strengths-based and how do we hire staff that are strengths-based in their approach. And then we quickly realized that we shouldn't limit it to just being strengths-based. We should look at those quality care themes. To develop the items in the attitude survey, we did a lot of research on, what's the literature saying, as well as our best practice understanding of those themes. Going back to Amy.
Yeah, and so the structure of the attitude survey, as Naomi said, we looked at a lot of other measures that didn't exactly, tap into what we're looking for, but as we were doing that, we also looked at structure and how those were structured. And we really, we saw a couple different paths assessments and surveys that were structured in this bipolar format, and we really liked that format and felt it fit well with what we were trying to do for the attitude survey. So the structure of the attitude survey is 20 bipolar items with 5 subscales. So you can see here kind of ice cream is delicious, ice cream is disgusting, and we asked folks to kind of rate on that 5-point scale, like where do you lean towards in your views. So then, next slide. Okay, so then, as we said before, subscales were aligned with those quality care priorities that you had seen previously, but we also added one additional subscale that measured openness to change, or kind of this idea of adaptability. You know, if maybe they didn't have all of the knowledge or about those 4 areas, but were they open to learning more or changing their beliefs and attitudes and the way they worked when they were in new settings and in new workplaces. So that was an additional subscale that we added. And we have the items so that some of them, the preferred response direction varies, so you don't get kind of response fatigue of always answering the same way. It takes about 10 minutes to complete in piloting that we've done. And as I had mentioned before, there is a version for frontline program staff and for administrative staff. And then we, so we had originally developed this kind of paper, and then we had done like survey type software, but we also more recently have developed an Excel version that has self-scores the subscales of the 5 areas and has a scoring guide that is included in the PDF version.
So I'm going to take you through some examples in each of the subscales of what we were asking people. So the first subscale, you see the 4 items here, and again, there's a statement A and a statement B. You're supposed to measure where you fit in between those 2 items. So just as an example, if you look at the last one here, staff should help clients develop life goals that go beyond managing symptoms of mental illness or substance abuse, or staff should focus their work on helping clients reduce symptoms of mental health or substance abuse. So the person who would be responding would say, I'm closer to thinking that the goal is to reduce symptoms, so I'm going to put my dot, far to the right, for example. Those are the 4 pieces on the recovery orientation. For the person-centered subscale, let's say the second one, if my client has a problem, I will share the solution if I know the best way to resolve the issue. Versus, if my client has a problem, I prefer to help them use their own ideas and skills to resolve the issue. So the more person-centered response would be closest to the answer, to the statement on the right. So we'd be looking for a dot closer to the right. On the trauma-informed care subscale, just as an example, the third one says, healing from past trauma does not require talking about what happened, versus in order to heal from past trauma, it is important for people to talk about what happened. Again, the desired answer in this case is on the right, not on the left. And these, by the way, we do not have this structured so that it's all the trauma questions together, all the person-centered questions together. They're all mixed up. And so you'd have things coming up all the time, different, topics coming up each time. The health subscale, let's see. So, for example, again, the last one, as a behavioral health provider, it is part of my job to encourage clients to practice healthy living. It says health living, but it should say healthy living, such as diet, exercise, or getting an annual flu shot. And then the other side is, it is none of my business whether or not my client is practicing healthy living. My concern is psychiatric symptoms and substance abuse. In this case, the desired response would be on the left side, so you'd want to see a dot closer there. And then in the openness to change subscale that Amy was talking about before, just as an example, first one, I enjoy a work environment that challenges me frequently with new ideas, versus I prefer a stable work environment where I can excel in work that is familiar to me. We tried to make both ends of the continuum not wholly undesirable, so that people wouldn't be kind of forced to answer just in the desirable way, but to really reflect actual feelings. I don't know how well that works fully, but we did try to test for that. So that was the program staff version, but we know that people who are administrative or non-program staff also, we would like them to also align with the quality care approach, even though they're not engaged in direct care. So we had a slightly different format where there are 8 questions as opposed to 20. And for each question, we're asking people to answer on a 5-point Likert scale. So it goes strongly agree, somewhat agree, neutral, somewhat disagree, strongly disagree. And there are 2 scales now. One is alignment with the quality care approach, and the other is what we're kind of calling being a good colleague in a quality care focused organization. So just as an example, when people act out, it's usually because they want attention. That would be alignment with quality care approach. The reason this might be important is, let's say you're hiring someone for a facilities or a maintenance position. There's a very different response you have when you understand that people might be having behavioral challenges for many different reasons, not just to get attention. When you're, say, the painter in a program, or you are the billing person in an ACT program, versus thinking that someone just wants attention, you may respond very differently. And so you want someone to be able to have the kind of attitudes that would align with that quality care approach, so that they would be more successful working in this setting. And an example of being a good colleague might be, I'm trying to look at these really quickly. In this job, I will not be responsible for individual clients. I need to focus on the skills I need to do my job well. Understanding this organization's approach to care is not really important for me. I would want my finance people to understand my approach to care, because if I start ordering blood pressure portable blood pressure machines, I don't want anyone questioning why I'm doing that. I want my finance people to get that that's an important part of what we're doing as a quality care aligned organization.
So there's several limitations to the attitude survey that I think it's important for us to mention. First of all, people that are completely new to the field without prior experience, their scores and the way they score may not necessarily be a result of a lack of openness or, negative attitudes, but really may be not being familiar with the field and with things and the concepts in the field. So that's one thing. Another thing is it is a self-assessment, right? It is someone rating their own attitudes. There's not external ratings of people rating like their behavior or their attitudes externally. It's their own views. And so that is also a limitation. And also, as mentioned previously, bias towards the desirable responses. We worked pretty hard to try and weed out items that we thought were pretty obvious what the desirable responses were, but there is a bias towards the desirable responses, especially for those who have been in the field for a long time. And also and this next one I think kind of relates to what I said in the first item, is lack of experience with those quality care concepts and understanding what those mean. It's difficult, it was very difficult to test the predictive capacity of the survey. You can't track people that don't end up not getting, that people that don't get the job, right? So it would be hard to see what happens with those. You can track people that complete the survey and then end up getting hired, and you can see what happens with their performance reviews, but you don't have that option to know more information about how those folks who didn't get hired. And then also, not all these questions have been fully tested yet. As we both have mentioned, this has kind of been this ongoing process where we've keep changing and tweaking things to perfect it along the way. And so we've done that yet again. And so there are some questions in the current version that were not included in the pilot test. And so those still, there's some more testing to do. And I think finally the last point here, which is very important, is that the results should not be the sole reason for not interviewing a candidate, right? Because of all of these different limitations that I just mentioned, like there are limitations to this. There is biases here, and there's things that you need to know more about the candidate and not make that judgment just based on this survey. So a little bit more about the development of the attitude survey. So we repeated the pilot testing of questions, and that led to modifications, and we have done that kind of several iterations of that. We tested it with existing employees. So folks who are ready were employed by the organization and had been employed for various lengths of time. And then we did also pilot test with some new employees as part of a new employee orientation. So modifications that we have made thus far, or modifications that were made, were as a result of phase validity. So asking folks, I mean, within the organization, and then, you know, the others who have been part of our team, do these items measure what they're intended to? Does it seem like we're tapping into what we think we're tapping into? Also, modifications were made based on pilot data that came in, and if we found that there was very limited variation in the responses, that was a signal to us that the question, the desired response was very obvious for everybody, and so that was a red flag to us that that was a question we just needed to take out because we weren't getting variation in the response there.
Also, there are questions that we took out because they were all undesirable responses, and we realized nobody could understand the questions.
Absolutely. And then, you know, doing some analyses, we found that there were some items that just had a lot of overlap in the responses and what they were measuring. And so we were able to get rid of some questions that were really tapping into similar things in order to not have too many items on the survey. Also, we started out with a larger scale, a number of possible response points. And based on pilot testing, decided we didn't need to have as many responses there, and so did decrease it to the current number of 5. Previously, we had 7. Yes.
Yep, we had 7. Now we're down to 5. It's making people are just exaggerating. You know, you'd find that people had higher scores not because they had bad attitudes; they were just people who tended to state things more extremely. So let's just take as our example, we're going back to our Pave the Way program. We've got 3 people coming in for interviews. We've got Marcus, we've got Lee, and we've got Rhiannon. Marcus has worked for 4 years in a similar program in another state. Lee's got 6 years experience worked, but all in hospital settings and all in hospital settings. And Rhiannon has worked for 10 years, but in 4 different programs, right? So we see their subscale scores. We see trauma, recovery, health, person-centered, and adaptability, or openness to change. So we look at this, there are some things that we highlight that we see as good, right? We see that Marcus has got a trauma-informed care score of 18, which is pretty good, and an adaptability score of 17, which is great. Lee, we see these recovery, health, and person-centered scores, 16 and 19. We're pretty happy with that. On the other hand, we're noticing that Rhiannon has got a couple of scores on trauma, adaptability, and person-centered approaches that are not spectacular, and Lee's adaptability score is also not fantastic. So at that point, we decide, went too fast. So we now know that we can use those scores, those low scores, as points for if we're bringing someone in for an interview, we're going to ask a few more questions. I want to probe a little further into these areas to find out what's going on, right? So now we get to the interview questions. And we did the interview questions in some detail on webinar number 4. So I'm going to go through this pretty quickly. But basically, we have 3 sets of interview questions. They're about, let's say, 20 to 30 interview questions for each of the topics. So for recovery and person-centered care, we have, these are the items on the left-hand side of the chart on the question category are the categories of questions, and for under each question category, we have 3 to 5 questions. So just as an example, openness to client participation in treatment planning would be something I might want to probe about somebody in terms of finding out how recovery or person-centered they are. So the statement or the question is, talk about your work with clients who do not consistently participate in the services on their treatment plan. And notice, I have not directed it to say, tell me about a success that you had with someone who did not consistently participate, but it's a very open, neutral statement. Talk about your work. Each of the recommended interview questions also has some specific questions for people who are applying for supervisory or leadership positions about what they would do to make sure that their program and their team are adhering to those quality care approaches. So this is on the recovery and person-centered version. On the integrated or whole health recommended interview questions, under supporting, so on the fourth thing down, under supporting individuals, your client does not have a trusting relationship with her endocrinologist. She has an appointment tomorrow. What will you do to support her? So that would help me understand about self-advocacy skills and interests. That would help me understand about the person's interest and ability to support around health literacy, about preparing for and how you're preparing for your appointment, all those kinds of things. And again, we have questions for supervisors and leaders. And then finally, on the trauma-informed version, there are questions about a variety of trauma-informed topics. And so just as an example, at the bottom on questions for supervisors and leaders, describe ways you both model and encourage trauma-informed care for your team. So I want to hear what you're doing. So with Pave the Way, with Marcus is coming in with his scores of 18 on trauma, 14 on recovery, 13 on health, 12 on person-centered, and 17 on adaptability. And remember that each of those individual subscores can go from 4 to 20. So my 18 on trauma is pretty good. My 12 on person-centered is less good. So I'm going to ask Marcus some additional questions, trying to find out where he stands on these things. So I selected 3 questions from the recovery and person-centered orientation interview questions and 2 additional questions from the health focus, right? If a person is making a decision you think will result in failure, what do you do? Tell me about something you've learned from a client. How would you define recovery in mental health or substance abuse, and how is that different from treatment? And from the health perspective, how have physical health challenges impacted your clients? What have you done from your end? What are some of the strategies you have used to help clients improve their wellness skills? These are just selections of questions from the whole array of questions that are available. All right. You can also use the attitude survey results to highlight areas that might require special attention during the initial months on the job, right? So Pave the Way decided to hire Marcus. And based on his responses in the interview, his experience, his resume, his attitude scores, all of it, his supervisor, Angela, starts working on a support and development plan as part of his onboarding experience. And so she decides that she's going to make it a point during supervision meetings with him to talk regularly about recovery and whole health approaches. She's going to go out of her way to schedule for Marcus opportunities for training and other kinds of information about recovery, health, and person-centered care. She's going to actually pair him with a more recovery-oriented colleague, someone who's really strong in that area, as a buddy for his initial couple of months. And at the same time, she's not ignoring those trauma skills, and she's going to solidify and reinforce those trauma skills and approaches to make sure he continues on that path. So then we've got Marcus, who's working at our Pave the Way program, and now we turn our attention to the performance measures tool. So the performance measures tool was developed as a complement to the attitude survey. Truth be told, we originally developed it as a way of trying to measure the predictive capacity of the attitude survey. That didn't work out so well. But we realized that a lot of times when we are doing performance evaluations and performance appraisals at the end of the year, we tend to focus on more generic topics and measures. So we look at teamwork and communication and supervision, but we're not looking at, is the person engaging in certain kinds of trauma-informed care or whole health supportive kinds of behaviors. So the idea is with the performance measures tool, it's the actual behavior on the job that's the goal, not having really supportive attitudes. I want to see it actually put into action. So we've established some basic standards of care, which then forces some interaction, some focus on those interactions. And if we think about it, a lot of times people, when asked to talk about how good their team members are, there's often a lot of talk about things like documentation and productivity, right? This person is great. They get all their notes in on time. Yeah, but how are they doing with clients? They seem to be doing okay, but they're really focused on the documentation. So we want to focus the attention on the actual quality of care. So we developed two versions of this. The first version was for frontline staff, and then we quickly, or not so quickly, realized that we needed another version for program directors and supervisors because they had different responsibilities. So these are some of the standards that we have created, and for each of these are the performance evaluation measures for frontline staff. And so for each of the 4 domains of quality care, trauma, recovery-oriented, person-centered, and integrated/whole health, we have 5 standards. So for trauma, are we seeing past trauma as an explanation for challenging behaviors? So that's kind of attribution. Are we routinely using de-escalation strategies? Are we helping the people we're working with develop coping strategies? Do we routinely offer choices, or do we mandate what they should be doing? Are we anticipating trauma triggers and trying our best to avoid those things, or are we just stepping into it? So this is actually a clip, whatever it's called, a snapshot of one of the actual measures. And you can see that there are, for each of the measures, it's a little more spelled out than on the previous slide, but there are 3 categories, essentially, right? And it's about frequency, how often. So it's never or rarely, sometimes or often. But we also know that for some people, it's not part of their job, right? And we also know that sometimes supervisors are not seeing those skills or don't know, especially in this era of remote supervision. We may not always be witnessing how people are actually doing their job. So we included that category as well as an option. For person-centered, these standards are about shared decision-making, avoiding labeling in language and documentation, making sure that services reflect the individual's priorities, not the program's priorities, being strengths-focused, and having person-identified goals and objectives. For recovery, are we supporting skill development? Are we looking at the barriers to skill development and helping people identify and resolve those barriers? Do we help clients find their own solutions to problems rather than solving it for them? Are we promoting social connections regardless of symptoms? And are we encouraging school, jobs, and other volunteer activities, again, regardless of symptoms? And then for whole health, we're looking at self-advocacy, skills to manage chronic illness, encouraging wellness and preventive care. Again, are we attributing unusual behavior ever to medical explanations and looking for those? And then focusing on social determinants. I'm going to turn over to Amy now.
Yes, and as the researcher, I'm back to tell you about the limitations. So actually, a few of these Naomi already mentioned. So first of all, lack of direct observation by the supervisor, the fact that they may not have the opportunity to observe these different behaviors, especially now, given the remote nature of a lot of the work. Also, another thing that limits the measure is the supervisor's understanding of the quality care standards. That could affect how they're rating those things if they don't fully understand or buy into some of these quality care standards. Also, the measure does not include anchors for frequency measures, and so it doesn't have concrete anchors about like how often something or a behavior is occurring. Measures are not specific to the job, right? So they are broader things so that this would be more applicable across different positions, but yes, it's not specific to each individual job and those responsibilities. And then finally, the program director and the supervisor version is still untested. That is one of the newer things that we developed, and we have not had a chance yet to test that. So a little bit more about the development and testing of the versions we have right now. So we did do a pilot test, and the subsample for analysis was 8 staff teams. The frontline staff completed the attitude survey, and then their program director or supervisor completed the performance measure tool. So we looked at correlations between the attitude survey and the performance measure. And that led us to, again, as we said earlier, modifications of both, honestly. When we started to look at the relationship between the two measures, we realized that there were things that we were tapping into in the performance measure, but then we didn't actually tap into in the attitude survey, and vice versa. And so that led us to changing questions, adding questions kind of on both measures. And you know, I think that as we were doing this, it really led us to thinking about how can the performance measure data be used. And so not just at the individual level where a supervisor could look and see where any particular employee was scoring, but also their team. You know, as a whole, if they looked at the data of the performance measures across the team, they could really see, oh, I see that the whole team is not scoring very well related to recovery. It seems like we need to do some work, some more focused training for the whole team in this area because we're not doing well across the board here. And so this really gives supervisors data about development for their whole team that they're working with and that they supervise.
Absolutely.
And then the next step is looking at that predictive capacity of the attitude survey and the connection to the performance measures. We did try to do that, but it didn't turn out that well because we were looking at a snapshot, really, and it was employees that were already employed by the agency. It wasn't like at the time of hiring or applying. It was actually people who were already employed, and so that means that they already had training on these areas. They already had base knowledge on the quality care domains, and so we realized we really needed to be able to take folks who completed the attitude survey at the time they were applying and look at performance measures further out. And we just didn't have the opportunity to do that yet. But we will because as I mentioned earlier, we did collect some pilot data from some folks at orientation earlier this year. And so our plan is to look at that predictive capacity with those folks at performance measures like 6 months out.
So this performance measures tool, we actually think it can be used in a lot of different ways. So one is a checklist for program directors on what are your expectations for staff behavior. This can be used as part of a performance appraisal system. It can be used as a tool to guide personal training and development plans. It can be a tool to help structure supervision sessions. It can be a decision point regarding data on, is this person eligible to complete the probationary period? And I also think it should be used as a benchmark for who is promotion eligible. You have to score a certain number of offens in your quality care behavior before we can consider you to move up the hierarchy, so that we make sure that we are quality care informed the whole way through. So if we go back to Marcus at Pave the Way, in his first annual performance assessment, all ratings that he has are sometimes or often. He's doing great. By year 2, 90% of his ratings are often. Year 3, he is 100% often on all of those different quality care performance measures. He is now eligible for promotion to supervisor. And after promotion, we're going to start assessing him using a different tool, the Director Supervisor tool. So the Director Supervisor tool looks at 3 domains: provision of quality clinical care, leadership and management, and how the leader is developing staff skills. So just as this is again a snapshot of that. So this is some of the measures under ensuring quality clinical care. And you can see by looking at this, it's not necessarily what the director is doing individually, but how they are making sure that their staff is doing it. So our staff using de-escalation strategies to support clients who are upset. Our staff considering explanations for challenging behavior related to health, trauma, and culture. Our staff aware of how they can trigger trauma responses and avoiding those. So it's about what the leader is doing to make that sure that it's happening routinely. So that's what we've got. We are really excited, and I saw that Tina Brown had asked about whether this is going to be available. It is absolutely available at the CTAC website. So you can go online. There's a PDF version of all the different tools there. There's also, as Amy mentioned before, an Excel version of the pre-employment attitude surveys. And the reason we have the Excel version is because the scoring is a little complicated, since some of the things are reverse scored and some are traditionally scored, so you have to do these adjustments in the numbers. So the Excel worksheet, if you put an X in the box, it'll automatically score what it's supposed to be. Can I just ask that everyone, let's see, when you get a chance, we invite you to fill out this survey. Oh, sorry, Tara just sent that out to everybody. If you can fill out the survey that will give us feedback to inform the future offerings, this would be fantastic. We are also, as part of this whole Workforce Priority Series, coming out with a full written list of answers to all the questions that have been posed throughout the entire 7-episode series. That should be available probably next week sometime. If you have additional questions about the toolkit, you can contact either me at ICL or Amy at the University of Kansas. We're super excited about this. We think it's a real resource for people who are looking for, how do I focus specifically on these quality measures? Of course, anyone's, you can mess with it however you want, but this is at least a structure to start thinking about it. If you have any questions now, we're open for business. So, and I'm just commenting again that Tina had said that she was looking online and only saw the job description interviewing tools. So this will be available next week, the toolkit, or tomorrow. Have you done anything with resources for administrative staff like compliance? So the response to that, so that would be, again, with the pre-employment attitude survey is where we would see compliance folks fitting in. We haven't put in performance measures or interview questions about it because the primary responsibilities of someone in, say, compliance or HR or facilities or whatever is really not about that quality care, but we just want to make sure people are thinking in the right way. You might want to add in a question or two that would be specific to those kind of quality care aligned themes into your performance appraisal. So you could say, for example, with an HR person, that the person is screening for quality care approaches and beliefs as part of the interviewing process and bringing in new staff. Or for finance is, treats all questions from clients and consumers in trauma-informed ways, just as examples. How do you choose which questions to use during the interview process, and how do you then compare candidates to answer different questions? Amy and I were just talking about that yesterday, knowing that what I would do, and Amy, I don't know how you feel about this, what I would do is have a standard set of questions that everybody gets, but I would probe further depending on the job responsibilities for particular candidates. So if I decided that, for example, people coming out of incarcerated settings, trauma should be a pretty high priority there, right? So I would probably want to ask some trauma questions for everybody who came through the interview process. But if somebody if we thought that it was really important that someone had a very strong knowledge of, say, substance use, I would add in some of those questions additionally. And that's how I would do the comparison across candidates. So Robert asked, how did you develop the subscales? Amy, you want to take this? Or want me to do it? That was Amy on mute saying you can do it. So the subscales were developed in part by looking through a lot of literature, a lot of existing scales measuring trauma and recovery-oriented care and whole health approaches, and then, and using, of course, our best practice knowledge, developing the questions and then tweaking them over and over and over again. The questions that you see in this final version are very different from what we started testing out last February, March, and then figuring out where they really fit in. So we know that the trauma questions were the trauma ones. The more challenging piece for us was the discrepancies or the differences between the person-centered and the recovery-oriented subscales, and trying to figure out where to place those, and just kind of looking deeply into what are the nuanced differences between those two very overlapping topics to ensure that we got the right things in the right places. Hope that answers that question. Other questions? Good, I'm glad, Robert. If nothing else is coming in, then I think we'll finish up and say thank you to everyone for tuning in. Again, please respond to the survey that's being posted or sent to you. Please look in, by Monday or Tuesday online to download the kit, take a look at it, see how it might work for your organization. And if you have questions, again, please contact either me or Amy. We are really eager to, answer any questions and keep things moving. So thank you.